Okay, welcome everybody to this afternoon's full meeting of the Joint Commissioning Board. We've had a number of apologies which are noted for the minutes. In terms of urgent announcements from myself, it gives me great pleasure to welcome Sarah Price as our new interim Chief Officer of Greater Manchester Health and Social Care Partnership, and also to welcome Steve Dixon, interim Chief Accountable Officer in Salford, replacing Anthony Hassel during his period of secondment. So well done to you both on those appointments. In terms of declarations of interest today, there's one obvious one which is around the primary care strategy. Rob and I had a discussion about it beforehand and think that all the GPs in the room should declare a potential conflict of interest, but that we don't need to step outside nor not be involved in the decision making. So is everybody comfortable with that? Okay, that's great. Just continue on very quickly with the admin. So please can we approve the minutes of the meeting from September 2019? Yeah, everybody happy to do that? Thank you. In terms of matters arising, Rob, you're going to pick up one or two around joint commissioning team priorities.
Thanks, Chair. It's just to confirm some changes in lead arrangements, largely as a result of Anthony's recent departure. So just for members to note and be aware of, our lead on climate change and sustainable development, Steve Dixon, will take on that lead role jointly with Sarah Price. For urgent and emergency care system reform, Martin Pritchard will take on that lead. For elective care reform, Steve Dixon will be picking that one up. And the improving specialist care lead will be Andrea Green. So just to note, colleagues.
Okay, thank you, Rob, and thank you for those of you who've stepped forward into those lead positions. Look forward to working with you all. Slight adjustment to the running order today. So in order to help Jackie Banney, who's here to talk about the Improving Specialist Care Programme, we're going to move that up the agenda. So that will be the next agenda item. So Sarah, are you introducing this one and then you're going straight to Jackie? So Jackie, the floor is yours. Thank you.
Thank you, and thank you very much for accommodating me around the agenda. So I'm just here to talk about two of the models of care today, and a quick reminder of the complicated roadmap that we have to follow in terms of the process and progress of these specialties through the programme. We're going to talk about respiratory and MSK today. Respiratory has moved quite a long way along the roadmap for reasons I'll explain in a moment, and there's a decision to be made on both of these, which I'll come on to. So what we're going to do is just two parts very quickly today. The first part around respiratory, and to summarise the model, remind you where we've come to, tell you or feedback the very positive response we got from the Greater Manchester Joint Health and Scrutiny Committee on the model of care, and ask for your decision, ask for your agreement to go straight to the direct business case, decision-making business case in July, hopefully. And then I'll explain where we've come to in orthopaedics in 1 second. So in respiratory, just to remind you, the model of care was originally agreed by this committee in November 2018. It aims to increase and improve the standards of care of respiratory disease across Greater Manchester. And the best way to do that, as considered by clinicians, is to concentrate on these three areas of chronic obstructive pulmonary disease, the way we manage influenza vaccination, and the pathways for community-acquired pneumonia. All of these pathways are all about primary care, community care, and public health, essentially, and how they interface with hospital specialist services. But essentially, the changes that we describe in the model of care are very much to be delivered within the local care organisations in the community. Therefore, they don't require any changes to acute sites. And it was because of this that we sought approval by NHSC to move straight to the joint overview and scrutiny decision part of the programme, because there is no substantial service change to patients anticipated by this programme. So in January, just 2 weeks ago, we took this model of care to the GM Health and Scrutiny Committee. They were very positive about it. They noted the link very strongly with the Strategic Clinical Network's work on respiratory medicine too, and highlighted there are specifically no negative impact for patients or the public, and better access after implementation of this pathway to high quality care around respiratory medicine. And as I said already, seamless integration with community services. They agreed that there was not any proposed impact for patients in regards to access or travel and no site changes, as I've said, and therefore they supported this model of care with clear benefits described. And I think you've had the actual model of care in your papers again today. So they agreed that we could recommend that we progress this model direct to decision making rather than going through a pre-consultation business case, because they don't think it requires public consultation, and that requires local OSCs to deliver via each locality whilst we get on with developing the case for your further consideration, hopefully in July. So in terms of respiratory, the first recommendation today is to support the progression of this model for respiratory services directly to a decision-making business case.
So can I suggest we take that part of the recommendation first and then move on to MSK Orthopaedics. So for members of the JCB executive, you'll recall we had a discussion about this in December and there was support for it, but because it's a key decision, we wanted to bring it to full JCB today. So any comments for Jackie or questions, please, on this recommendation? No, seems fairly straightforward. So are we happy to approve the recommendation to proceed directly to a decision-making business case to be presented to us in July 2020? Yeah, okay, that's approved. Thank you, Jack.
Thank you. And so on to the orthopaedic model of care, or musculoskeletal model of care. So once again, this model of care originally, before we started looking at sites in particular, was approved by this committee in October 2018. And originally, the model of care suggested a sort of four-tiered network service across Greater Manchester with one super specialist centre, two specialist centres, 4 joint centres, and then the rest of the emergency trauma provision being as is in local hospitals. That progressed then to site-specific modelling, and through last year, some members of the committee were present at 2 workshops that we had when we started looking at how that looks in terms of sites. And when we started looking at it in a site-specific way, there were ostensibly 2 choices, but both of these choices, if we'd implemented one or the other, would leave stranded costs and had a capital cost to them. So when we did the further analysis on the site-specific, we didn't think that was desirable, and we asked the team to go away and see if they could mitigate any of those costs. There was also a feeling throughout the year that a lot of the standards and the aims of the model of care, which was to increase the standards of care and redress variability across Greater Manchester, could actually be delivered through getting it right first time standards in a very much a standardised way without necessarily moving sites. And so we came to some discussions in December, towards the end of last year, in the programme where the Improving Specialist Care Board appraised the revisions and felt that there was still a strong case that remained to support change, but not necessarily in the way that the model had originally anticipated. We felt, in terms of the board, that there was a case for partial implementation of the model, and that being largely around the super centre, because these are small volumes, high-risk procedures that should be done in one place where the appropriate infrastructure is there for them. I'll come back to that in a moment, but that we did not have any disagreement with as a board. There had been issues raised by the external clinical assurance panel about the relationship to trauma, and this still needed addressing. It still hadn't been addressed sufficiently in the model of care by the time we reviewed it in December. And once again, we came back to the fact that you could address and improve the standards of care across Greater Manchester with by the implementation of getting it right first time programmes without necessarily causing any change of site location. We also, within this model of care, seek to benefit patients that are also being cared for in the independent sector to have the same application of standards of care, and that remains an ambition of this programme. And also, having a whole-scale Greater Manchester approach to procurement in orthopaedics is also recommended that we continue with that work. However, we come to some recommendations from the board that seek your agreement to change how we approach orthopaedics across Greater Manchester. There is already established a Greater Manchester Orthopaedic Alliance, which is an alliance of all trusts and providers of orthopaedic care, very much clinically led, and that's been established for many years and was part of the modelling in terms of and the guidance in terms of the development of the model. But what we seek now to do is to progress elements of this model of care, but to go for an overall approach in terms of the revised approach, but actually to remove it from or decouple it from the programme and implement the changes that we want to implement, that we should implement, through a more of a local or sector commissioning approach to work up the configuration so that there can be deliberation of by this committee in due course. So it doesn't remove it from the overall decision making here, but that rather than the programme progressing a model which didn't seem fit for purpose any longer, to progress it through the directors of commissioning and therefore determine how best these services are configured in the future. But as I say in recommendation B here, the limited scale that we want to actually move forward on through the directors of commissioning work and for the work that's already been done in terms of the modelling is on the super specialist work, i.e. the 4 procedures that are required that are very very complex and very bespoke and need a super centre approach to it. So recommendation B basically is asking you to agree a revised approach to the consolidation of orthopaedic activity on a more limited scale than was anticipated in the original model of care, as was evaluated last year. And the approach generally is to address this through getting it right first time standards across all localities, with the organisations providing the care as is in our localities, both elective and trauma care. But in recommendation C, we seek to uncouple the programme of work from the Improving Specialist Care programme and develop it through directors of commissioning, because there's still a case for, as I said, the 4 procedures for the super centre, and then knee revisions. Indications are that there is some benefit to consolidating those knee revisions. But if we did them according to the original model of care, we would end up with the other issues, which are the stranded costs and the capital costs. So we need to seek a different way of configuring knee revisions yet to be determined. So those two are kind of linked, recommendation B and C, but I hope that's clear, and I can ask for Sarah's assistance if I haven't made it clear. I'll pause there.
Do you want to go through all the recommendations?
Yeah, okay, I can go to the last one, yeah.
Any discussion? Okay.
So the recommendation D is the one where we just specifically support the consolidation of the super specialist clinical activity at Wrightington, Wigan and Leigh, already an established super centre for orthopaedic care, and there are 4 procedures that we would seek to deliver there if they're not delivered there already, and that gets the benefits of low volume, highly complex activity being delivered by expert surgeons who are used to operating on those patients with those conditions. The second cohort of activity, which hasn't yet been progressed, but we are recommending is progressed by the commissioners, the directors of commissioning, is the knee revision replacements, which there are too many to be put in one centre. And we don't know how many centres would be beneficial to have in Greater Manchester to consolidate knee revisions, but they again are quite complex procedures and would benefit from expert consolidated provision. And the final recommendation is not to support the original proposals of establishing joint centres, because this would be moving what we've got now in terms of elective activity in all our local hospitals into 4 centres, and that was the one that would cause a lot of movement of patients and activity around the system for no savings and in fact more cost actually. So that's why we are not recommending that and seek your approval to agree that.
Okay. So we're talking about relatively low numbers of patients who would be impacted upon, but those that would be required to travel further potentially, it would be to improve
their outcomes, because they have a very specific and very specialist procedure required.
Okay. Thank you, Jackie. That's clear. Any questions for Jackie, please? Martin and then Tim, please.
Apologies if this is in the paper, Jackie. I looked for it, couldn't find it. Could you just confirm that in decoupling this from the ISC programme, there's no impact on the other models of care or the other options or choices in the rest of the ISC programme?
Yeah, there are no codependencies clinically or otherwise on the other specialties and in the other
estates or any other?
No, because we're not moving or changing the estate.
Okay, thanks, Tim.
Yeah, thank you for that. I suppose there's two questions and a broader point. I suppose absolutely welcome the paper there. It's quite clear what you're describing. I suppose there's a clarification just with that point D, the super specialist hospital, although it's only a few hundred patients. Are we clear about the need to consult for those numbers of patients, about that recommendation? The second is, I think, we had a system in place where there are some great hospitals, great clinicians, but there is considerable variation. And getting it right first time has been around for a number of years. So are we confident going back to the current system is going to transform those variation outcomes? And then finally, with point E, if we're going to move away from the proposed clinical model of care because it's involving moving a lot of patients, a lot of change, whilst that might be the right decision, having reflected on the process, are we equally clear that all of our current programmes or other future programmes, is there a need to reflect on some of those as well?
Okay, I'm going to try and remember all three. I think the point made about the consultation is a good one, and we need to seek further guidance on that, even though it is low numbers. It may not be necessary, but we will seek further guidance. In terms of the second one, getting it right first time. Yeah, it has been around a long time. And actually, I recall before we started the Improving Specialist Care programme, we were getting traction through the Greater Manchester Orthopaedic Alliance by benchmarking. And all trusts were very happy to benchmark and share their data about where we could improve and who was best practice in which procedure and how we could all level up. So I think with some concerted effort through commissioning and localities as well as the Alliance, I do believe that we can address and take that further. It has kind of, it hasn't progressed as quickly because of this programme of work, which has kind of slowed that collaboration down a little, I think. And on the last one, thus far, we don't think there is any need to change any of the other models of care, and we've in fact took 5 of them through this committee, I think in December. But we're going to pre-consultation business cases, which may cause further decision-making changes when it comes back to the committee in due course, I think. So I think time will tell, but we're not anticipating that at this stage. But the whole purpose of developing pre-consultation business cases is entirely to determine that.
Okay, thank you, Jackie, for that answer. Jess?
Yes, I just wanted to comment on behalf of the Directors of Commissioning, just to say that we are keen and willing and able to take on this programme and from the recommendations being seen. We'd like to get on with it.
Okay, thank you very much, Jess. Eamon?
It's just a question that I'm sure leaders will raise. I mean, the one thing you can't accuse Wrightington of being is central in terms of GM. So is any modelling being done in terms of public transport accessibility and impact on patients and visitors?
Yes, in the programme. I can't give you the detail right now. We will have to go back to that along with the question of consultation, I think.
Okay, any other comments? Okay, are we happy to proceed to the recommendations, please? Okay, so recommendation D. Sorry, can we go back a slide, actually? Because we need to do B and C. Okay, so let's do recommendation B, which is to do a more limited scale than anticipated in the initial model of care. We're happy to agree with that. Thank you. Recommendation C, the uncoupling of MSK orthopaedics from the Improving Specialist Care programme. Yeah. And then next slide, please. Recommendation D, consolidation of an appropriate super specialist centre at Wrightington for the 4 procedures previously outlined, but a second cohort of activity will require further work by the Directors of Commissioning. Are we happy to adopt that recommendation? And then finally, not to support proposals around elective orthopaedic centres or specialist units. So just the super specialist. Yeah. Okay. Right, thank you. Thank you very much, Jackie. We can let you go. Okay, so thanks everybody there for your patience as we work through all of those recommendations, but I thought it was important to take them one by one. Right, moving us back up the agenda to homeless healthcare and the Bed Every Night scheme. Ruth, I think you're going to lead us off here, are you? Thank you.
Okay, thanks, Tom. So I'm going to invite Helen to the table to join us. Thanks, Helen. So we're working as a team on your behalf, Martin, Kath, myself, Helen, Warren and Rob, and we're now represented at the GM programme, Homelessness Programme Board, and this was our agreed report back to you at the midway point for the year that we've invested into. So I'm going to actually hand over to Helen, who does a great deal of hard work on our behalf, and this is her paper, so she'll do much better justice to it than I will.
Thank you, Ruth. So as Ruth just stated, this was really a halfway report on activity we'd undertaken in the first 6 months since the investment was agreed, both from JCB and the Health and Social Care Partnership into a Bed Every Night rough sleeper accommodation scheme. And at the point of investment, there was really two specific strands of work that we wanted to pick up. One, ensuring that a Bed Every Night continued to run as the emergency rough sleeper accommodation across Greater Manchester, and that we move that into a more formalised model of provision. But also from a health and care perspective, that we wanted to use the period to improve our understanding and strategic oversight of homeless healthcare across Greater Manchester, to identify some practical actions that we could take forward in that 12-month period, and then to use all of this to help inform a longer-term model of provision for homeless healthcare across Greater Manchester. So as you'll see in the paper, in terms of an update on a Bed Every Night as a programme specifically, Phase 2 launched in June 2019, and that was with a much more collaborative funding model than we'd seen previously, and that really reflected that Greater Manchester-wide commitment to the rough sleeping agenda. Having that 12-month funding commitment meant that we could enter into a more formalised arrangement with localities in terms of that provision, that was based very much around improving the quality of accommodation. There was more focus around move on and driving down the length of stay and putting in place a better monitoring and assurance process. These types of improvements are captured in a specification framework with localities, so that even though provision looks different in different areas across Greater Manchester, we're working very much to the same standards right across all the provision. Again, as you'll see from the figures in the paper, the utilisation has continued to be high, so over 2,000 referrals over that first 6-month period of Phase 2, an increase in bed numbers to around 450 over winter, but that kind of has to be seen in the context really of a substantial drop in our rough sleeper count, 37% decrease over a 12-month period and 44% since 2017. The only other thing really to add around Bed Every Night and what we'd expect to see over the next six-month period, alongside the continuation of the programme, is the commissioning of an evaluation, which hopefully will start to inform any future iterations of emergency rough sleeper accommodation within that wider homelessness infrastructure across Greater Manchester. So in terms of that second specific strand of work, so activity from a health and care perspective, so we initially set up a task and finish group, which is chaired by Ruth, and that was to give some oversight to the investment agreement, again to those practical elements as well, but also to ensure we're having a continued conversation about homeless healthcare across Greater Manchester. The objectives of that group were quite clear. We wanted to better understand the need in the population around the health needs of people who are experiencing homelessness. We wanted to better understand the provision that already existed across Greater Manchester to support people experiencing homelessness, and use all of this understanding and increased knowledge to help us to inform and oversee a better model longer term around shifting towards prevention, utilising our understanding of what best looks like and trying to get to a point where we had a comprehensive understanding of what that should look like across the 10 localities. The work that we undertook really, the work that we identified we wanted to do was really led by the work that we already knew was going on and very active in some localities, so very much building on that activity that we already knew was working really well. But alongside that, trying to identify the areas where we knew that some Greater Manchester presence could add some value. So, for example, the work that we wanted to do around supporting development of our workforce, both from a clinical and homelessness perspective, to improve the offer to people experiencing homelessness. So over the last 6 months, in terms of meeting these objectives, we've undertaken a comprehensive health needs assessment in some of our bed every night provision. So looking at the presenting health needs of that cohort of people, working with Urban Village and Manchester University. We've worked with the homelessness team here at Gmca to ensure that some health-related standards were included in the specification in terms of improving accommodation, built very much on the comprehensive work that the Booth Centre have done around temporary accommodation standards, looking at things like infection control and bed spacing. We've developed a really comprehensive training and education offer for our bed every night frontline staff and volunteers, which we're hoping will turn into a longer-term learning network. And we're launching that this Friday with input from a number of sector experts around things like trauma-informed approaches, exploitation, substance misuse, health issues and barriers to accessing healthcare. We've also undertaken another detailed audit of all of the healthcare services across Greater Manchester that are already provided or commissioned to support people experiencing homelessness, and that was very much building on two similar exercises we'd already undertaken over previous years, but this time very much focused on the provision or the additional provision that had been aligned to a bed every night, but then also reflecting the increased provision that we always see every time we undertake one of these audits. We've proactively engaged with our GP practices that are in close proximity to a bed every night provision, really to encourage them to engage and also share some examples of best practice and models that are already working well in terms of local GPs supporting that cohort of people. And we've established a network of homeless healthcare leads across all 10 localities. The next 6 months really will see a continuation of this work. So further workforce development, shifting over really to the clinical side, so rolling out of the GP homeless and inclusion health training with clinicians and practice staff. We'll explore options for standardised processes around GP registration. We want to support individual localities to undertake the same health needs assessment that we did in the bed every night provision. We're already seeing some localities start to pick that work up. We'll also be providing support where it's appropriate to the agreed case management processes within localities, looking at those with most complex needs who aren't accessing a bed every night. I think most importantly, what we want to see in this next 6 months is a shift and broadening in that conversation around homeless health. So the launch of our Homeless Families Task and Finish group, we'll start to see some of that broadening out of the conversation, and that'll be very much informed by the work undertaken by Shared Health. So we'll start to look at that issue in more detail, improve our understanding and make some appropriate recommendations around models of support. So as this work's developed and progressed over that initial 6-month period, the halfway point feels quite opportune to start to consider any future commitments around homeless healthcare so that we can be quite proactive in setting out our intentions in this space. I know a conversation's taken place previously around that. The initial bed every night investment paper last June set out quite clearly that our future focus should be on longer term response to prevention and early help, and any locality investment should be primarily into provision of homeless healthcare. So we're proposing a process to review that initial commitment in the paper, potentially to take place at February JCB, informed by the questions at the end of this paper, which are based very much on trying to get a local understanding of need and priorities, not just around that complex end and those people who are accessing a bed every night, but a real shift towards prevention and understanding the need for preventative services for people and families who are experiencing homelessness. So I'll hand back over to Ruth.
Thanks, Helen. I'll give Kath and Martin a chance to comment if they want to as well, but I just wanted to say thanks for the presentation, but maybe what doesn't necessarily come through in a paper like this is the richness of the conversations we've been able to have as a result of being present when health hasn't necessarily been at the table in the discussions around homelessness at GM until now. And there's a lot of clinical knowledge and understanding, which is actually fundamental to the work that all of us do in our work in primary care, but also obviously expertise, particularly amongst our mental health colleagues. And, I think we have been able to move some conversations on, particularly when we're down to talking about individuals. I think it's been important that we've been there. I think the other thing that's been really helpful is to have a constant reminder of the differences between localities as well as the similarities. And I don't know if that sort of leads into anything you want to add to where we're up to so far, Kath.
I don't think there's anything to add really from other than I think it's very easy to be focused on Manchester in the discussions, but it is a whole Greater Manchester problem, and it's been useful for me to be thinking about this strategically at GM whilst also looking after patients in our local hospital across the road from the practice as well, and kind of use the two to help kind of design what we might need in this next phase and then in the future as well. So no, a big thank you to Helen for her work in pulling this together and for the work that we've done in the last 6 months.
Okay, that's great. Thanks very much. Real team effort, and I think that's the way it's been, hasn't it, really, since last June. So well done to everybody involved. Any comments in terms of the updates? You know, the précis we've received, which was really well constructed, actually, Helen. No, I think it's pretty straightforward. Obviously, a lot of work going on in this area. There's a clear ask of us in terms of the recommendations for us to go back to our localities and think about the questions that have been set out, and then for us to come back together in JCB at our in February, at our JCB executive meeting. So is everybody comfortable with the outlined approach as per the recommendations? Okay. Any burning desire to say anything about those recommendations, or we're all ready to go? Okay, that's great. So thank you, Helen. Okay, doing a great job, and we're happy to approve recommendations. Okay, that's great. I'm going to move us on to our next agenda item, which is establishing an integrated Greater Manchester sexual health and reproductive health system. And Sarah, I think you're leading us off on this. Thank you.
Thank you very much. So some of you were here in February last year where we talked about the development of a sexual and reproductive health strategy and an approach, a joined-up approach across Greater Manchester. And one of the challenges, particularly in this area of work, is that the commissioners of sexual health services include just about everyone. So obviously the CCGs have a role, local government has a role, and NHS England specialised commissioning has a role to play. And the real opportunity in GM and within this group is that we can bring all of that together and start to look at how we join up services in a way that makes sense for individuals within the community, but also makes the most efficient and best use of the resources that we're all committing to this very important area of work. So I don't intend to talk too much about the strategy itself because people have been working on that and will bring back a more detailed kind of proposal about how we might implement some of that in a couple of months' time. But what I did want to talk to you about was about decision making and about how we do that. But just to give you a feel, we're seeing a decreased use of contraception, and this isn't unique to Greater Manchester, but we are seeing it here, and perhaps a bigger decrease here than perhaps in other areas. An increased use of emergency contraception, the morning after pill, an increase in abortion rates, continued high and increasing rates of sexually transmitted infections, and high rates of late diagnosis. So we have, as I say, this real opportunity to look across the whole system and see where we can make the best use of our resources and take a whole system approach to decision making. So this was the model that we presented in February, really thinking about how do you integrate. So we need to do something about what we can do with digital. Other places have used this, but I think we've got a real opportunity to really step forward on digital and self-care. We need to work with communities, with the community voluntary sector. They do huge amounts in this area. What do we do to support and develop their input? And then in terms of primary care, the whole of primary care, how can we enhance and support them to really provide support to people from their communities. And then specialist care, as I say, huge amounts of money spent on HIV treatment and care. The nature of HIV has changed. It is more of a long-term condition now. How do we therefore change the way that we look after people and allow them to look after themselves and manage their own ill health? So really a different model. And underpinning all of that, we need common standards. We need to take a much more outcomes-based approach. We need to make sure we're doing the right things at locality level and doing what we need to do at GM or other level as appropriate. And just to emphasise the responsibility for commissioning, these are the things that different people commission. Great long lists there, but in other areas you can't bring those together in the way that we do. And by taking that whole system, we think we can improve. So what we're proposing is that we strengthen community provision and self-care as a first phase. So during this calendar year into next year, we look at the digital offer and try and work that forward, work with primary care to think about what that enhanced offer, both across general practice and pharmacy, could be, and then specifically focusing on HIV prevention and treatment as we move into next year, with a view that in 2022 onwards we'd be looking at commissioning a single model for providing specialist provision and a specific focus on complex HIV and complex contraception, so breaking it down into sizable chunks really. And those are the sorts of things that we're talking about doing. I wanted to talk about, therefore, how we make decisions. This group brings together all of those areas of commissioning, and what we've done so far hasn't required us to bring all of that together. So local government commissioning hasn't been done here yet. We've been talking with Liz Tracy in terms of how we might get the delegation in order to be able to do that. But before we go any further, we wanted to make sure that everybody in this room was keen to move forward across this agenda and work through the detail so that we can bring it back to you as this being the decision-making forum for sexual and reproductive health. So that's the key question. Is this the system decision taker in relation to this programme of work? And then we just need to agree what the steps are in order that we can make that decision so that we can come back with proper business proposals in April.
Okay, thank you. I guess also it's not just about the role of the Joint Commissioning Board, but also our sub-governance in terms of directors of commissioning and potentially their role in this. So first of all, can we test out the appetite around the JCB becoming the decision maker for this? Sue, please.
Thanks a lot. The presentation's very helpful. What it and the paper didn't quite get across to me, though, is what you're seeking the level of decision to be. So you're talking about the JCB being a system decision taker. So does that mean you want to delegate all commissioning decision-making for all aspects of sexual and reproductive health to this group? Because the things you've put on the slide don't seem, as the programme of work to do, don't seem to suggest that that is necessary. So to do some work around specialist HIV services across GM, we may need to commission that as one, like we've done with more acute high-end services in other areas, but for really ensuring that we deliver good and coordinated services across GM through our other aspects of commissioning in community, secondary care, etc., primary care, it sounded more like we could do with a few either principles or standards, or a commissioning set of standards that we agree here by consensus but wouldn't need any delegation for. So my reading of this is that there needs to be something that makes clear the case for delegating the commissioning decision making for HIV services in future, but also then sets the scene for us to develop standards together. And I think in the past we've developed standards together by consensus and then commissioned in our separate areas to meet those standards. So it's just a proposal.
Okay, thank you. So, Sarah, can I suggest we take a few questions and then perhaps come back to you for your thoughts? So, Sarah, please.
Thank you, Sarah. I think we kind of agree that this is the most appropriate way forward, but it didn't feel to me as though the complexity of the commissioning in the locality is really reflected, and that it is so complicated with multiple providers with different pots of money that it just didn't feel as though that was demonstrated as well as it could have been. And we also kind of felt that the time frame around it was incredibly ambitious, given that level of complexity is we're aware of. It did feel very much as though from the business proposal through to getting this all sorted by December is really very ambitious. The thing as well that was missing for me as well was the level of scrutiny around the decision making, and maybe that attached to the standards that was just previously suggested, that, you know, where does the scrutiny around the decision making come into that? That seemed to be a gap as well for us.
Okay, thank you. Good points. Bev, then Keith, then John. So Bev next, please.
Thanks. So I tried to focus on things that I thought might be helpful to move us beyond just having that broad discussion today, because I agree with Sue that I think for me the principle of developing an integrated system is one that absolutely we all would, I imagine, in this room welcome and support. But I think the detail of what that would entail is probably where it's going to get more complex. And I think we probably need to be quite explicit from the off as to what it is that we're actually seeking to do at JCB and how we tease that out. I think things that would be helpful for me when kind of having a more detailed discussion, because I think this paper is a good starter for 10, but there's probably a lot more analysis that would have to go into it. And I think the fundamental question really that we would be seeking to do is not, is this the right kind of service to deliver at an economy of scale, but what would we want to achieve by economies of scale? So teasing out a little bit more around what the vision would be beyond simply having it integrated, but what that would do for people and for outcomes and for access. So I think a little bit of a thought through what we at a GM level, think our population needs is probably a good base to then take us through into the next elements of decision making. I think the beginning of digital, I think, is one that is really quite urgent, and I think that's something that we could all broadly agree that there should be something at a GM level around a digital offer that simply a locality offer may not be able to meet. We are way behind in GM, particularly when you look at London and some of the London boroughs and Greater London services, particularly around access to testing. We're also quite behind when we think about high authorisation in relationship to the VCSE work in terms of testing points of access. I think there's significant variance across the region that we could seek to address fairly quickly, actually, without getting ourselves caught up in a lengthier discussion. I think that will need to be more evidence-based. I think other things for me that need to be teased out are how would an integrated service fit with GUM and secondary care offers at the moment, not just around primary care. I think how we look at the need, I think, for some areas to have more community-focused, neighbourhood-focused offerings such as contraception, and how that integrates into our neighbourhood model should also then be balanced around communities of identity across the conurbation as well, and for some communities, particularly those in LGBT plus communities that wouldn't perhaps feel as comfortable accessing what we wouldn't medically deem as specialist care, but what those communities would perceive as something that will have their own issues. So I think geography and identity is probably something that would need to be thought through in an integrated offer as well. And then the final thing that probably jumps out to me is there is reference to VCSE-led work within this, but behind all of that, I think sits decades worth of engagement at local authorities, CCG and GM levels, both in statutory, non-statutory and voluntary sectors. So how we think about engagement and co-production and some of those elements in our future offers as well. So I think broadly and in principle, I think it's good that we're getting to this, because I think it's a really, for me, it's a really meaty piece of work that will tease out what I see as some of the fundamental JCB decision-making and governance questions that we'll have for everything. So I think we should maybe see this as a bit of a test case as to how we move ourselves forward, but balancing pace with making sure that we get the processes and systems right, I think, for future decision making as well.
Thanks, Bev. Well said. Keith, please.
Yeah, pretty much along the lines that Bev was just speaking about. I mean, I think overall you can support this as a move in the right direction, but I'm not clear what we're being asked to agree here in terms of the detail and the opportunity for localities to shape their service around what they want. Are we trying to impose a one-size-fits-all across GM in an integrated service? Just what does that mean? And I think, you know, whilst I can agree with the general direction of travel, I think we need a lot more detailed information about how that would operate, how it would run, and what we would be expected to do. I mean, I can clearly see that it would be important for this board to set down those bedrock things around variation, around clinical standards, around outcomes, around all that. That would, to set a bedrock and a framework around what sexual and reproductive health services should be, is really important. But I'm not quite sure what we're being asked to do here, and I think certainly we need more discussion and more detailed information about just what it means. Because within the report there's a reference to the voluntary and community sector and a particular provider. Well, we all operate with a variety of providers across our localities. And for me, I'd certainly want to operate with somebody who shared the values, beliefs and principles of our local authority, and also somebody who was signed up to our ethical provider framework as well. So there are a range of things that I think, you know, whilst we can support the general direction of where we want to go, I think we're a long way from that, and there's certainly a lot of detailed work needs to be done in consultation.
Okay, thanks, Keith. So I'm going to bring John in, but before I do, Sarah, what I'm going to do is, when I bring you back for a response to these comments, I'm also going to ask you to think of what is the best way forward in light of the comments received. You know, what's a realistic timescale so that we can do this safely. John.
I think I'm finding some difficulty in terms of relating to this particular paper because I'm really enthusiastic about the idea of some universality of provision across the whole of the conurbation. But I temper that with a realisation that we are an enormously diverse set of communities. Most of us as local authorities have become used to working with those communities. It's not about restricting access to services, but it is about sometimes how you advocate those particular services to take account of community needs and community sensitivities. And I'm very reluctant, I think, from Salford to say, I'll hand over all of that to some sort of other body to determine that and to provide that. So yes, I'm in favour of a digital provision that's available to all across the Greater Manchester. Yes, I'm in favour to specialist services being available on a universal basis. But beyond that, I want to have a role in designing the services to reflect the local needs of my particular community. And I think that's what I'm not seeing yet in terms of what you're actually proposing.
Okay, thank you, John. So I'm going to bring Sarah in now. Thanks.
Thank you. All very helpful comments and reflections. I think just taking up Sue's very first point about are we asking for anything to be delegated now, I think we're talking about how we work through whether there are things. So for a digital offer, there will need to be some decision made at some point about who's going to lead that work and how's it going to roll out across Greater Manchester. So we would need to make a decision here probably to be able to do that. I think there are other aspects of care as we move to new ways of working that might mean that care that takes place currently in a secondary care setting would actually really be better provided at a locality or a sub-locality level, absolutely. And that would change the nature of the type of service that probably we want to commission from secondary, when I say specialist, I mean secondary specialist care rather than tertiary. And You know, we do a huge amount, for example, of contraception prescribing in secondary care at the moment, and that can't be a good use of resource. So we should do that differently, and that should be something that's done at a locality level, whichever way we decide to do it, whether it's through community voluntary sector or whether we do it through primary care, pharmacy, etc. But there are going to be some things that we have contracts for at the moment around GU services that we might want to do differently as a result of that change in the model of care. It's not going to be about medical management in the same way that it has been in the past with secondary oversight of people with HIV, for example. So if we're going to do that differently, what do we need to invest in differently at locality level? But what therefore do we need at a GM, or, you know, universally across GM? Do we need as many centres as we've got at the moment? Could we invest that money differently? Could we improve the offer for people? And I think it's that we need to think about in terms of what we might do together. And yes, build on the bedrock of the standards and outcomes, etc. In terms of who might provide all of that, obviously each locality is currently working in a group. I think apart from Wigan, I think everybody else is within a group, and those contracts will come to an end, and we may want to talk to each other about how we might do that differently. Do we still want to work in the groups that we're in at the moment? How do we set standards around social value, etc., around those contracts? Because we certainly want to make sure that we are developing our community voluntary sector and supporting them in their development, as well as local providers. So absolutely take the point, Keith, about what we might do around that. So I suppose in terms of next steps, I think obviously need to pull together a bit more detail around what we might be proposing to bring back before we get to anything like a business case. But I think separating out what we're talking about doing that we might do together versus what we might be doing at a locality level obviously needs to be a bit clearer and a bit more detailed than it is at the moment for people to take it forward. And picking up on what Bev's been saying, it might be good for us to do a more in-depth session perhaps with leads around this area and directors of public health, for example, as a way of having that conversation going forward.
Okay, thank you. So, Sue, you want to comment?
Picking up that, I was going to make a suggestion, Tom, because you talked about our substructure. We have Jess in the room. There are chairs of appropriate groups like the Directors of Strategic Commissioning and the DOCS. That really directors of public health need to, I think they have questions about the commissioning process, and that would be a good discussion to have to then bring back some proposals that put the weight on this paper, that pick up the questions people had in the room. So I think, you know, using the right people to discuss how can we get the right groups together to do that would be helpful.
We might be able to do that through the Strategic Commissioning Group, mightn't we? As all those people are represented there, as well as having a discussion with lead members.
Okay, thanks. So I think a really helpful discussion. I did go back to Bev's point that this is potentially a bit of a test case for us as a joint commissioning board in terms of how we may want to look to work in the future. But I think at the moment, Sarah, we're probably not in a position to accept the recommendations as outlined, and that further work needs to take place outside of this meeting with the relevant groups involved. Potentially, you know, every quarterly cycle of joint commissioning board meetings, we now have a development session planned for March. It might be that we want to bring something back there so we can have more of a discussion once more detail is known. But you know, we've opened a conversation today, but I think there's a lot more to be decided before we'd be able to receive a business case. Is everybody supportive of what I've outlined there? Okay, thank you. It feels a bit like the Sarah show today. Sarah, the final agenda item today we are receiving is the primary care strategy. Are you able to perhaps just lead us off here, please?
Yeah, so thank you, Chair. And if she doesn't mind, I'll call on Jess later, because she is the lead for this group on primary care. So just to say, really, many of you will have seen this strategy in other groups and in other, you know, iterations, and hopefully is fairly self-descriptive. This is an update, so it's not a new strategy really. It's an update of the existing strategy that was pulled together for 2017 when we allocated transformation funding to primary care. 41.2 million has been invested in primary care. And as part of the requirements around the LTP, primary care was something that people were required to develop a strategy on. So it was a good point at which we could refresh what we were doing and have a look and see how far we've gone. It's been an opportunity to renew our ambition for primary care in the context of our place-based working and our place-based approach. And it takes on board some of the success that we've had, improving access, the rollout of that, training for admin and clerical staff. I think we've trained over 1,700 staff now. We've developed dementia friends, a community pharmacy, and the rollout of enhanced site tests for people with learning disabilities. We've done lots of things to improve access to primary care. The focus really of the strategy is to try to look at the integration at neighbourhood level, improving quality and delivering sustainability. So the workforce element particularly picks up on that, and how do we sustain primary care into the future. So the workforce strategy really acts as a key enabler to the delivery of the strategy overall. Both strategies are deliberately high level to enable them to be interpreted and implemented at a locality level. So this isn't saying that one size fits all, we do this once across GM. It's saying this is the direction of travel we want to go in, and we want to support a locality level to deliver. Having said that, the workforce strategy is absolutely key to be able to really deliver this. It looks at all of primary care. There is sometimes a tendency to focus just on general practice for very important reasons, but we have the opportunity here in Greater Manchester to really bring on board our pharmacists, optometrists and dentists as well as general practice in moving those forwards. And what we have done through the workforce strategy is try to look at the interface between primary care, local care organisations, community care, secondary care and the VCSE sector in order that we can make the very best use of the resources we've got and intervene at the earliest possible point, making sure we've got the right people in the right jobs in the right places. The plan for the oversight of all of this would be through the primary care group that Jess chairs, and then there's a workforce core steering group which sits underneath that that would oversee that workforce interventions, and that feeds through to the strategic workforce collaboration that Karen James chairs for the partnership as a whole. Really just ask you to receive both those. It's been to every group possible on numerous occasions, so I hope people have felt that they've had a hand in shaping this. They're due to go to Partnership Executive Board on Thursday, but obviously if there are comments from here we'll be able to include those. Jess, I don't know if you wanted to say anything further.
Nothing really to add. Perfect summary. I think just to say that obviously this has been a long time in the making. Getting here has been considerable amount of iterations, particularly in picking up the PCNs and making sure that those are embedded within the whole system and driving that forward. I think what we now need to do is move on to the implementation plan. We've got a lot of work to do in this area.
Yes, please. Thank you. So it's very detailed. I appreciate it. A lot of time and effort must have gone into it. I think just bearing in mind what you've said in sort of contextualising it, just to reflect maybe the next steps. So I read it twice just to be sure that I was receiving it in the way it felt for me. And as someone who is absolutely passionate, and yes, as a GP, but appreciating that this is broader than general practice, I don't think that necessarily comes through. So if we're thinking about neighbourhoods and stability and workforce and encouraging people to both stay and to come and join us in Greater Manchester, it may not be for this paper, but we have to be able to explain how incredible it is to have the privilege to work with people in the way that we do in the community, and why so many of us do tolerate working under the pressures that we do and stick with our communities, you know, at times of increasing workload. So it would just be lovely to feel that we at JCB, given that there are quite a few primary care practitioners in this room, if we could influence the momentum behind that as we move forwards, because there's so much to celebrate, and it is in that paper, but there's so much more to celebrate perhaps than has been captured, which is part of those small everyday relationships which a lot of our descriptors about our neighbourhoods are very much trying to drive towards. And I think those relationships with our voluntary sector partners and our neighbourhood teams in particular that reference to the same sort of richness of being part of the community. So I'd love it if that could be the next step for us.
We, in our locality, we are very aligned with what the overall plan is, and we've already delivered most of the things that have come through, and including the workforce strategy as well. Though it is very important that we do build our workforce for the future, and there are enough workforce existing for the work that needs to be done within our communities. I also want to just bring to attention the work and the efforts on trying to retain the experienced workforce that we already have in our system, because though this is absolutely essential that we build the new workforce, but that takes time, and also the new workforce will not have the experience that the experienced clinicians, or not necessarily clinicians, the experienced workforce that's already there in the community. And I think that there needs to be some more emphasis on that part of retaining that skill that is there, because the amount of time and efficiency and effectiveness that is provided by these workforce, it cannot be replicated by the new workforce that is coming in. So I think just to put some more emphasis on that part, please.
Okay, thanks, Ash. John.
Thank you, Chair. So, mindful that making a pointer now when this has been described as being in so many fora is a little bit untimely, and maybe I've missed some workshops, but for me it's a central question of, have we as GM absolutely maximised the potential of the fact that community pharmacy has been brought into the primary care family? And if we don't think we have maximised that potential, how does the strategy speak to that? So very quickly, I think the worst money we spend in GM is on medicine that nobody takes and perhaps nobody issues. And that quantum conservatively is £20 million, which is an interesting figure when you think about our deficit conversation from an hour ago. I think the most clinically risky thing we do is say we've issued a medicine and it's not been taken. So the clinicians in the room hopefully will nod their heads that when we look at our computer and see 12 inhalers issued every month, we then think that that patient's long-term condition is controlled. But actually, if that medication isn't used and isn't issued, then a job isn't helped. A&E attendances are not decreased. So there's something about a missed opportunity, which is my perception, that primary care is more than general practice. We've started to work with our pharmacists in GM. I understand that their contract is different, that the team is small, but I think we as a system have not mined the potential of that increased relationship. And I don't see it in this strategy that, you know, I see a box, but I don't see described how we absolutely get a grip on the flow of medicine, because I think it's significant financially, and I think it's significant clinically, the performance of the pharmacy sector of primary care.
Thank you, John. Ian, would you like to come in?
Thank you. The implementation plan contains a lot of proposals and ideas. I would welcome understanding the decision-making process for the allocation of any additional money which comes in association with that, because it's not clear to me from the many priorities what would receive funding and what wouldn't receive funding, because I'm sure that would be an issue. So, for example, would any new money be held centrally on the basis of a bidding process by localities, or would it be shared out to localities working to commonly agreed standards, as has been described previously? So what I'd like to propose, conscious of time, is that in relation to the third recommendation, Tom, which asks us to approve the implementation plan, I would request that we either defer that or we agree that subject to agreement and understanding by the DOFs, the CFOs and the CLG accountable officer group, because I prefer to understand that rather than just give complete support now.
Okay, so Steve, do you want to come in on this point?
Yeah, in my former role, we did have that exact same conversation at Chief Finance Officers and Directors of Commissioning when we saw this implementation plan, and we couldn't commit to some of the comments that were in there around the funding, and what we said was broadly supportive, but each one of these would need to be considered on case by case, because the funding is very complicated in terms of whether it's part of the GM devolution STP monies, whether it's in CCG baselines, etc., etc. So each one of these would need to be worked through and agreed explicitly in terms of where the funding currently sits and who agrees to fund it. So that should have found its way into the comment on the cover sheet, but I don't think on the implementation plan there's a specific table in here that hasn't been updated. But yeah, that was raised at CFOs and Directors of Commissioning. So I'd be happy to support the implementation plan with a caveat around the funding streams, and decisions around the funding needs to be explicitly agreed on a case-by-case basis on those areas.
Okay, thanks. So, Rob, do you want to
Tom,
come
yeah,
in?
just to add to that, just for colleagues' reference, on page 43 on the cover sheet, there is that specific point that Steve has just made. There is a specific point, recognition there is no financial commitment from CCGs, and CCGs will implement as appropriate, which is on the Directors of Commissioning bit and replicated for the Directors of Finance. So that was the basis upon which the docs and the Directors of Commissioning and the CFOs were happy for it to come here with their support on that, with that particular caveat.
Okay, thank you. Ian?
Thank you for that. It doesn't fully answer the point I was making, which is that in addition to that point, there's a question of how new resources are allocated, what the decision-making process is about those, whether that's resource held centrally by GM for bidding process or whether it's locality-based. So that's why I was proposing that we have a further discussion within the accountable officer group, for example, to understand that more fully.
Just on that, any money that's coming into Greater Manchester as part of the new allocations and the STP there's a workshop at the end of this month to work through that very question in terms of what's retained at a GM level for GM delivery, what is passed down to localities for locality delivery and implementation. Primary care is just one aspect of that, so we won't be looking at primary care in isolation in terms of the totality of the money that's coming into Greater Manchester, but that's what that workshop at the end of this month should be getting into.
And any and every workshop should be accompanied by proper formal decision making based on governance. So a workshop on its own is great, but it's not necessarily sufficient.
To start the conversations at the workshop to come back to CLG in the first instance.
Okay, so in terms of that particular recommendation, is everybody comfortable if we do introduce the caveat around funding streams and that we delegate responsibility specifically around that to CLG, which stands for something leadership, commissioning leadership group?
I think no, I do have to say that obviously primary care monies it's a broader discussion, isn't it? That primary care board will have a view about how money should be spent, and the allocations that are made need to be explained and looked at, and assumptions that are made about what's gone into baselines and things like that from a national point of view. But for example, there is specific money allocated for PCN development, and that's tagged as such. And this year that's been divided with I think it was 2.4 million, 1.4, 2.3, 2.4, something like that. 1.3, 1.4 went to localities, and 1 million was held centrally to develop to provide development support that might be common across all 10. So, you know, I suppose it's not straightforward, I suppose is the point I'm trying to make, and that some of it will be dictated nationally because it will be contractually paid to practices directly.
Okay, so Sue?
So rather than decision CLG, can I suggest that what we're looking for is assurance as to whether the implementation plan is deliverable and funded? And CLG can certainly come back to this group with assurance as to whether it is deliverable and funded based on the work it can do.
Okay, so I think although it's a technical point, it is important for us to get this right in terms of the recommendations. So I think we can support the revised primary care strategy, but I'm not sure that we can actually fully support the implementation plan at the moment, that we need further detail on that before the JCB can commit to support. Is that a reasonable? Yeah, okay. Martin?
Just to build on that, Tom, is there an agreed timescale for the implementation plan for the workforce strategy?
In terms of when it will be? Sorry, in terms of when it will be ready. I think we can do it fairly quickly once we've agreed that that's the direction of travel. I think some of the people plan, you know, allocations may well affect what we do and the requirements in the LTP. So in terms of what we have to deliver, so numbers of GPs and numbers of, we will be expected to contribute to those numbers, I think, in the same way that everyone else is across England.
Okay, so perhaps it could be an action, Lindsay, from today that we try to get a bit more information around the delivery aspects of the workforce strategy, so that you know, we don't necessarily know the answer today, but we might be able to come back February or March or April with that information. Okay, so just quickly going through the recommendations, we note the progress. We were able to support the revised primary care strategy, but not currently the implementation plan. We will need to bring that back once further detail is known, and we're able to support the primary care workforce strategy. Yeah, okay, and I think we have agreed next steps in terms of the work that still needs to be done. Just an observation, if we look at the agenda today, sometimes the connectivity between points, so we've had a discussion around primary care and homeless, and I didn't sort of see that coming through particularly strongly in the strategy. And then we've had a discussion around an enhanced sexual health offer that will be largely general practice based, and I could see stuff from the community pharmacist, but I couldn't see you know, that as part of the strategy. So you know, it's just interesting how we've had 3 agenda items and in some ways two of them actually don't connect as well as they could into this strategy. But I appreciate this document has been a long time being developed, and we want to be able to sort of sign it off and move it on. And the key thing is going to be the successful implementation of it with the appropriate funds. Could I add to an outcome measure that if every GP was able to offer a 15-minute appointment for routine consultations, that would have a massive impact on the quality of care that we can deliver. You know, so we've got a lot of process outcome measures potentially, but you know, an ambition of ours has to be to move to 15 minutes as a standard for a GP consultation. And on that little banging of the drum, do we have any other business? None in advance?
It's just the update from the forgive me, the most popular item on the agenda, I'm sure. Just to mention a couple of things, though. There was an issue with quoracy in November, so therefore the November meeting we actually ran as an executive, and its proceedings are reported here. On that basis, just for the record, I wanted to place into the public domain that we did agree in that November meeting that we are going to move to a quarterly cycle of meetings, people might recall. So month 1, so this is month 1, we have a meeting in public. Month 2, which will be next month, we have an executive. And month 3, we do a development session with all members invited to all sessions. So again, we've agreed that previously, but this is to just to place that into the public domain, and with scope to run additional meetings in public if the business demands it. Linked to that, I just wanted to mention that last week, the Task and Finish group that you set up around organisational development met. We've appointed an organisational development partner. The company is called Satva, but the person that's going to be running the event is a chap called Ian Roberts, who might be known to some people because he has done work in Greater Manchester previously. So he will run the session in March, and we'll be working with all of us. In fact, I think there's going to be a questionnaire. A short questionnaire issued to members to make sure we get the best from those sessions. So just to place those on the record, Tom.
Thank you, Rob, and sorry for ignoring your agenda item. You can tell me off later. I don't think we have any other business. No. So we'll draw the meeting to a close. Thank you very much, everybody, for your attendance and input.